I am Sheela Roth from Pearl, Head of Clinical Education, and we are really excited. We have Dr. Lou Graham here today, and we are co-hosting this webinar with our Patterson team. So I'm going to turn it over to Lori. She's our Field Marketing Manager from Patterson. She's going to kick us off, and then we will introduce Lou and walk you through the world of 2D AI. Thanks again for spending your time with us. Lori, thanks for being here with us today.
Yeah, hi everybody. Just on behalf of Patterson Dental and Pearl, I'd like to welcome everyone. We're so glad you could join us today. We are looking forward to hearing from Dr. Graham and sharing more about Pearl AI. As Sheila said, my name is Lori. I work on our product marketing team at Patterson Dental. Prior to my time on my team now, I spent 3 years as a territory rep in Denver. So having said that, I spent, my fair share of time partnering with vendors and introducing new products to all of my offices. So what I can say is all of the products I have shared with my offices, Pearl has been the most well received and from all team members. There really are benefits for each person in the office. So, this is why we're so glad to not only partner with Pearl, but to have integrations in both EagleSoft and our cloud-based solution Fuse. So thanks again, guys, for joining us today. I'm going to turn it back over to Sheila at Pearl to get us started.
Excellent. Thank you, Lori. And I can attest to that working with the Patterson team and the native integration. So exciting to see what they're bringing to you today. Without further ado, I will introduce Dr. Lou Graham. Dr. Graham has quite the history in the dental space, not only being a director in a previous dental school, but owning a practice, being the founder of the Catapult Group, and also being able to walk us through a consistent way to really focus on patient care in a minimally invasive type of dentistry approach. And as he walks us through today, I want you to open your mind to all of the things that we're facing on a daily basis with radiograph review, case presentations, and Lou's going to share how to overcome some of those obstacles.
Welcome, everybody. I'm going to walk you through how my experience over the last 4 years has really involved 2D AI from really its infancy into really its impact within our practice of 4 hygienists, 4 GPs, periodontists, and an endodontist. So I'll start off and say it's great to be here. And let's start off with the sad truth. And the sad truth is that you go to school for years and years, and you spend hours upon hours of studying, and yet the perception of dentistry can be this. So this is from TikTok, and in TikTok, I know there's a ton of stuff going on, but this guy is broadcasting our dentist running the biggest scam in America, which I find truly, truly offensive. And when you look at the comments section here with over almost 3,000 comments, and you see all the comments by other people, whether dentistry is a money grab, dentistry is a scam, here's the deal, if it doesn't hurt, let them fix anything. I really feel that we've gone from a trusted profession via now an online medium where there can be a lot of distrust, and it's shared distrust. And when you add this to the component of where we're at today, that people may actually trust computers more than human beings. And when you also look at the fact that you have an increasing concern over the intrusion of algorithms, and it's a key word today in daily life, but people may be more willing to trust a computer than a fellow human being. And so that's what we're going to talk about today. How do we integrate both into our practices? And I see this as really a huge challenge for every team member in the practice, every team member. And so I want to start with building trust today. And as we build trust, you have to ask yourself then, what is trust? And when you look and ask yourself, what is trust? Trust really has 6 key components. I talk about reliability. I talk about sincerity. I talk about commitment, consistency, competence, and integrity. Each of these 6 key items runs into trust. And how do you get the most important aspect in your office is the patient to trust you? It's really the most important thing. And for these 6 traits, really to build trust, I would tell you the most important thing is listening to your patient. You got to listen. Why are they there? What are their concerns? What kind of personality are they? And then how do you offer the most appropriate diagnostics to customize their care? And that's today's course. Optimizing 2D AI into all your practices and how it can, and you have to understand this, how it can help you build trust with your patients. Like, you can think your patients should just trust you, but given the parameters and all the noise we're at today, how do we optimize that trust? So I want to start with really an interesting thought. Imagine flipping a coin and you went into Google and you typed in dental radiography, sensitivity, and specificity. And if you did do that, this is what comes up. Sensitivity in general is the ability to, or the probability of a positive diagnostic test when disease is present. So if a cavity is there, how often is the sensitivity 100%? In other words, whatever you're imaging or whatever you're testing is there 100%. Specificity means there's no disease, nothing's going on, and how accurate then is the specificity. So if we take that into account, let's start with calculus. Digital radiography had an average sensitivity of 50%. So the calculus is there, and yet radiographs and your eyes are identifying it only 50% of the time. If it's not there, the accuracy goes much higher to 82%. Well, they found that the larger the calculus, the more sensitive you are in detecting it. No kidding. So right now it's really 50-50 just in detecting calculus. Let's go to caries. And when you look at caries, it has a sensitivity of 58%. So what does that mean? In teeth that clinically scored as showing dental caries, only 58% were found to have radiotranslucency or translucency. So we're at, again, 58% for dental x-rays, for caries. So let's show you a patient named Jim. So Jim comes in, seeing me, and I'm taking out an old composite that's breaking down. And when you look at this, how good is your sensitivity on reading this x-ray? Do you see decay on the number 1 icon, the number 2 icon, or the number 3 icon? Where do you see decay? Do you see decay? And I would tell you you're guessing. And this is routinely what I've seen in my career, where all of a sudden you start taking out the composite and there you see decay on the mesial of the 2. Yet you look at that x-ray and now you go, maybe it's there. There was nothing on the distal. And And again, do we really want to be guessing? And that's my biggest concern. So let's take a look then at a next case. I'm following a patient, lower bicuspids. Let's take even a closer look. On the distal of number 20, you see no decay. You don't see it. Yet, using in this case, Caries View, which is a NIRI technology, near infrared radiation, you can see quite clearly there's distal caries, and we would call them D2 caries, well into dentin. Well evident. And 2 years later on this X-ray, you can see the restoration and the depth of the restoration. But yet, if you look at the comparative slide in 2015, you wouldn't have seen it. We would have been guessing. So many dentists out there have dropped into an occlusal and then see lateral caries interproximally, and you're looking at your X-ray and going, I see nothing. And that's the discrepancy of how accurate we can read X-rays with our eyes. Let's talk periapical pathology. The study showed dentists correctly identify periapical pathology 43% of the time. So it's there, but we're not correctly assessing it. And bone loss, we're correctly assessing only 57% of the time. So basically, these are the challenges. And when you look at 2D imaging, which has its own restrictions, that this was a patient who came into our office. They were swollen over the summer, and 2D radiographics showed maybe a small lesion on the top of the second bicuspid. But when you take a 3D image, it's as clear as day. I mean, if you don't see the 3D image, then you've got a problem. But these are limitations with 2D images, which gets me back to decades and decades and decades of research have shown that basically we're flipping a coin. Dentists use explorers, dentists use and hygienists use X-rays. Explorers are incredibly inaccurate for fissure decay because of fluoride remineralization, and X-rays truly are limited with our own eyes of what we're looking at. And as it currently stands, and maybe this is where some of the mistrust lies in our profession, dentistry is still a very, very subjective profession. Very. Because if you put two dentists in a room, you could get 3 opinions. And you all know exactly what I'm talking about. If there's a hygienist watching today, if you brought 2 or 3 dentists in your own practice, or 2 or 3 dentists you've worked for, you're going to get multiple opinions, often on the same lesion. And this is the reason we need 2D AI. I am absolutely convinced that every practice can benefit from 2D AI. I have no doubt about it. And I break it down into 3 concepts of success. The first is diagnosis. You're going to see enhanced diagnostics. The second is opportunity, which I'll explain. And the third is communication. And this is for everybody in the practice. So when you look at diagnostically, what 2D AI brings to the table, you have to understand that AI can detect more shades of gray than the human eye. You just have to understand that in the study in the bottom of the screen, they said humans can identify 30 shades of gray. Well, if AI is trained and can identify between 500 and 800 shades of gray, this is how it can be a great asset and a great adjunct to your practices. So case at hand, 2 studies, just 2 I'm going to show you. This study, which is titled Deep Learning Approaches for Caries Detection and segmentation on dental bite wing x-rays shows the sensitivity, again, the correct diagnosis if caries are present, with AI went up into the 80th percentiles. So we're increasing this almost 25 to 30% with AI from our own eyes. Well, I think that's huge. I think everybody in here would think that's huge. Now, if you also understand that based on the AI algorithms to really detect more dental caries or the lack thereof dental caries, that will make us far more, I think, efficient. And you'll see why this will make you more efficient in how you read x-rays. And I think far more, I think, diagnostic. So I think diagnostically for caries, this is huge. Let's talk bone loss. So this was a study where they're talking about deep neural networks for evaluating bone loss. And I earlier showed you we were in the 57% range. Now we're in the mid to high 80s. So again, a 30% jump in seeing more bone loss and AI identifying that bone loss. Yeah, it's easy to identify greater bone loss, but it still has a better efficacy of mild to moderate bone loss. And I'm going to bring this all together in clinical and show you how this works. You just have to understand the benefits of 2D AI. The second thing that most people don't know is the opportunity at hand with 2D AI. Because what's going on is that the computers are basically now evaluating your x-rays. Pearl, Overjet, companies like them, they've injected tremendous amounts of data into computers to train them on how to read x-rays. And because they can evaluate grayscale so much better, that's how 2D AI can really help. So you take this proprietary softwares, now you add the algorithms that obviously you don't see, machine deep learning, and this is 2D AI. And with this information, computers are seeing opportunities that your offices have missed each and every day in our patients' x-rays. This is probably the biggest home run of what Pearl and similar companies offer. So what kind of data are they pulling out? They're pulling out data to identify areas for implants. Usually those are either, I would call it edentulous areas, or they're teeth that cannot be salvaged. They're gone. They got to be removed. Those would be implant opportunities. Endodontics would routinely be lesions that are seen on the x-rays. I'm going to get into scaling. Restorative really breaks down into two. Is it new decay or is it recurrent decay? And all of this data is compiled office by office. So this is the data from Pearl that I'm going to share with you in my own office. So I'm going to show you we're not perfect. My team's not perfect. Lou Graham's not perfect. And you know what? Neither are you out there. So why not have 2D AI? Don't be intimidated by it. I would say grasp it. So let me just show you a couple of opportunity funnels. If we look at over the last 12 months and just go to the focus on number one there, endo candidates. An endo candidate is defined by finding periapical pathology. If you look at the number 214 next to endo candidates, only 57.8% of those lesions have been found in our practice. So basically they're sitting there, we haven't identified them, and so we've only treatment planned 57.8%. If you identify 5 or 10 more of those, it pays for Pearl for a year, and that's just endo. Now you look at scaling candidates, I saw this in our office. We had a hygiene meeting and my hygienists were not happy with what I was sharing with them. And I got 4 great hygienists. And what the software identified using calculus and bone loss, which I'm going to show you, we had only correctly treatment planned 24% of all our scaling candidates. Only 24%. Pearl identifies all of this and even has additional graphs for your team. And this is a graph that shows you planning performance. We were lowest in scaling and planning, meaning we underdiagnosed. Yes, we had completed a high percentage of those treatments, which is great, but we hadn't treatment planned a lot of work, meaning we missed it. So in the morning, when I go in and I'm now going to explain the dashboard, I just want to highlight in 1 week how many scaling opportunities we did not identify in a practice. You want to talk about ROI? This is ROI. These are 4 days of patients. Monday, Tuesday, Wednesday, and Friday. Thursday, I think we took a team day that week. We identified 15 scaling patients in 4 days. Now that could be a 4341 or a 4342. You know what you charge for a 4341 and a 4342. And these were all not treatment plan patients. So I really believe, as much as we focus on new patients, there's so much work in our offices that we have just not found. We have not identified. And we owe it to our patients to treatment plan them correctly. So I'm just going to walk you through how I do kind of my morning huddles. And this is my morning data courtesy of Pearl. So I had a patient scheduled for 3 p.m. that day. I'm in my office at 6:30. I start at 7. And she's a 79-year-old lady, upper denture, lower partial. We've made those. And we've done some minor restorations on her. And in the past, my morning routine would always be reading through my electronic charts and x-rays. That's what my morning routine is. And I'm sure it's the same morning routine. If you're not getting to the office and prepping for your day, I think that's a big mistake and you're going to really run behind. So I'm a really big planner for my day. So 4 or 5 years ago now, could be 5 at this point, I really brought in Pearl as a beta test for the company. And as I brought them into the company, I'm going to show you just the impact in one patient, Bridget, in my morning huddle. In her case, and I'm just highlighting now my notes page in our computer system, my associate had identified on her last recall appointment caries on 25 distal. And with caries on 25 distal, they set up a half an hour. Fine. So she's coming in for a half an hour. And then you could go, okay, what's the big deal, Lou? So this is how I go through my notes forever in my career. And I would ask each of you, how much time do you spend on an x-ray? And it's usually probably most people would say 5 to 10 seconds max. And yet you look at what's on an x-ray here, 7 composites, a crown, a root canal, a post, potential caries, potential pathology, tooth anatomy, bone anatomy, all on one x-ray. 5 seconds? Wow, it's a lot. So now with second opinion, I want to show you how this is going to impact your diagnostics and how it impacted our schedule at the office. When you take your x-rays and the Pearl software comes up, what you're looking for are dots. And the dots are color-coded. So the AI has now identified where my arrow is, a pink dot, which is caries, on one x-ray, and a blue dot, which is periapical pathology. So now instead of just reading all your x-rays, which you'll do anyway, and you probably do this in 15 or 20 seconds, now you're going to be focusing on what Pearl found. And when you look at what Pearl found here in a comparison of what we traditionally look at and what Pearl found, man, there's a lot of data here. A lot of data, which we're going to go in and identify step by step. So the first thing is I will tell you is that you take you open up your x-ray in second opinion now, you move your cursor over to the caries, and it will show you how deep the caries is. Is it how much cementum, dentin, and enamel? Well, there's no doubt we're going to restore this patient, but it's also telling you data. As you move your cursor over to number 22, it has now identified a second lesion that my doctor missed on the exam and my hygienist missed. So now I've got an additional caries that needs to be treated. But there's more. What was missed was the radiolucency. Just like the data suggests, we miss radiolucencies. So this data is always on. I'm just highlighting it individually, but each icon is always on. So now we've missed the radiolucency, and I'm seeing this in my morning review. I'm catching this all because second opinion in my morning review of this patient is giving me all this information in seconds. This is the bone measurement. All of this data is coming to me. Part of Pearl, it allows you to do a lot with this data. One of those is to measure the lesions. So there's a measurement button, there's a contrast button, there's a zoom button. And all of this can be used in front of the patient or prepping for your day. So when you look at a typical black and white x-ray versus Pearl, who would want a black and white x-ray? Nobody. There's no reason you'd want that, because look at how much more information and how fast you can assess it and plan your day and plan your visits. So now here's the tough question. So she's coming into the practice at 3 o'clock. It's 6:30 in my office, and I need more information. So what am I going to do? I'm going to go back and want to see, had I missed this lesion in the past? Is it growing? And so what we did is we pulled up 4 x-rays of over 7 years. And in 2014, I didn't see it. 2015, you can start to see it. I didn't identify it. 2018, I was not the one at the office that visit. It's definitely present. And a year before, in 2021, you can absolutely see that lesion is growing. It was never identified in my office, and I'm the first one to admit I missed it in 2015. Other doctors missed it in 18, 21, and 22. And you know what? Nobody wants to miss these things. This is why you want 2D AI. Now, how did this end up changing the appointment? So I hate stress. I hate running behind. So we called the patient and told them we're going to change the appointment to 60 minutes. Dr. Graham found an additional cavity, and we're going to need to take a cone beam on the patient to identify an area. Now, my front team person may say, Dr. Graham, in reviewing your x-rays, has some concerns, so he wants to add time on your visit. That's all that has to be said. But the fact is, the patient now knows I'm prepping before they're coming in. That shows more value, more trust. I take the CBCT, I explain to the patient what's going on, and often they may not even need an endo consult, because I'll take the CBCT, send it to the endodontist, and we make a plan. So my patients may not even need a separate consult. And this is the courtesy I give to my patients. This builds trust. because I'm doing all this for my patients, and this is why I've been PPO free my entire career. I just believe you go the added distance, and this is what Pearl allowed me. There's no doubt this adds communication. And let me just show you from a hygienist standpoint, of course, from the doctor standpoint, but from the hygienist standpoint, I think it's even more critical, more essential. So for me, I'm showing it in my initial exams, but routinely it's periodic bite wings that we're taking. And I don't even routinely take FMXs anymore because we just do that with a cone beam. So we take bite wings and CBCTs. So this is how you up your game on a recall exam. This is the circle. This is how I break down an hour for a patient, an hour, not a half an hour, an hour. And this is for prophies or perio maintenances. The initial, I'll call it 5 minutes, is the hygienist building her relationship, his or her relationship with the patient, establishing credibility. We've got some new tests in the office. I went to a course. This is what the doctor's looking at doing. You're just building office credibility. The hygienists are trained in our office to do no more than 20 to 25 minutes of therapy on a patient. We're not talking scaling and planing. We're talking routine prophies or perio maintenances. It's 20 to 25 minutes because the bulk of the time then is clinical screenings. And the problem is that traditional diagnostics, A, they were not sensitive enough, and they're not set up to enhance communication. Let me show you what I mean. Traditionally, we've used explorers, which are not accurate, perio probes, which are very subjective based on angle, pressure, and even bleeding on probing is only 30% predictive of future disease, only 30%. And so the normal armamentarium in most hygiene operatories is an explorer, a probe, and an x-ray. And we've kind of gone through all three earlier today. This is how I bring it home for all of you. So I believe enhanced diagnostics equates to enhanced trust and ultimately far more treatment plan conversions. Absolutely far more. So what are we doing in our office? We use Velscope as part of our oral cancer screening. We know when patients are due for their CBCTs. We use transillumination or NIRI and fluorescence as caries diagnostics. Our patients can be scanned every year digitally, looking for tooth movement, recession, wear, occlusion. 2D AI is now obviously incorporated. We have intraoral cameras, and now we have genetic tests and salivary tests. And you're going, how can you do all this? That's why we need clinical screening time. You start doing all of this for your patients. I'm just telling you, this is how we have 4 full-time hygienists. And when they get a cancellation, that patient may have to wait another month until there's another opening because we bring so much more value add, and 2D AI is part of that. And now after the hygienist is going through her findings and prepping for the doctor to come in, this is how we look at it. Are you going to just tell the patient? Of course not. You're going to sit them up. You're going to pull that monitor over, and you're going to start to show them what's going on in their mouth. And if you involve them, like I'm talking about, they're going to understand this. They're going to want their work done because they're going to understand they need to have this work done. So when you look at it, whether we find a lesion on Velscope, deeper caries on 2D AI using a different imaging part of 2D AI with Pearl called tooth parts, which I'll show you, or you're showing occlusal wear with iTero over a year and a changing occlusion. This is where hygiene's going. And if you want to be PPO free, and I know it's hard, but I can tell you there are absolute ways to do this in every practice. And I am not in a wealthy area at all. So what I'd like to do is really show you a case. And I want to show you the value of AI in exams. And it's huge in initial exams, but I'm going to bring up a recall exam, and it's on a patient named Rosa. So Rosa comes in. She's your 67-year-old patient. She's got implant dentistry, restorative dentistry, a history of perio treatments for 20 years. She's a type 2 diabetic, long struggle with A1C, now has developed cardiac issues and high blood pressure. She flosses twice a day. She's a power brusher, and she wears a night guard. So you think all should be good. So we take a routine x-rays that day on her. And immediately with Pearl, what comes up are where those check boxes are. She's got calculus, caries noted, caries progressed noticed, and a periapical radiolucency. It all comes up instantly. So we click on second opinion. And in second opinion, there's your boxes and there's your dots. And all four quadrants of her bite wings, all four quadrants on her bite wings have subgingival calculus. Some have caries, and there's a periapical pathology on one of her PAs. Okay? So now she's got 4 bite wings with calculus. I want to focus on only number 1 because we're limited in time. This is what you normally pull up. Watch how I'm going to blow you away and how you're going to have so much more information. And I'm just going to walk you through icon by icon how my hygienist does this. First icon she's going to show is subgingival calculus. Lower molar on the distal of the canine. She's showing the patient what has been identified. Now, could you have caught this? Maybe on number 30, but I doubt on number 6. But this is what AI does. Now, let's talk bone measurements. So now we're looking at bone measurements from the CEJ to the crest of the bone. Look how much more detailed this image is than just a typical black and white image. Now, if you click on the icon tooth parts, now all of a sudden you can explain what's going on with subgingival calculus, not probing depth, but bone depth, but yet you can identify the different tooth parts so it's all colorized. But I think the money in this patient, the money was comparing past images. So let me show you comparing. We went in and compared from 2023 to 2024. And if you look, the distal of number 4 has progressed from a white, what we call reading, to an orange reading, which means we have progressive bone loss. On the mesial of her upper bicuspid in yellow, it has progressed to orange. So she's losing bone year over year. We're showing you, and yet could you really identify that without this? I'm going to say no. And on the bottom bicuspid, it went from a normal CEJ to crestal bone, and she has lost some bone. And that's why it's in yellow. You can see that a new area of subgingival calculus was found on the distal of the canine. All of this enhances your opportunity after you probed her. So when you look at her probings and her bleeding, her probings and bleeding on probing scores, she has 24 bleeding points. Now you're going to do that through perio probing. She's been identified with 2D AI as far as having subgingival calculus and continued bone loss. And her blood tests have shown she's got A1C challenges. How are you going to get her diabetes under control if she's got active periodontal disease? You know it's all related. You know it's all related. And now as your office starts to take all of this information, what are you going to do? Are you just going to do a perio maintenance or a prophy on this patient? Of course not. You're going to do active therapy. So now you're going to book her for active therapy. And whether you want to do bacterial DNA testing, saliva testing, or genetic testing, that's another course on another day of what we do. And as a hygienist, are you bringing in the latest of specialty products like Slate, which is a power flosser, Live Fresh, which is a toothpaste that removes 250% more plaque than all the leading brands out there that we routinely are giving as samples? Are you going to offer her a probiotic? Are you going to put her on Perio Protect? There are so many more things we can be doing for our patients once we identify the problems. And I feel 2D AI really complements the process. When the patient is reevaluated in 3 months, you may do a bacterial or saliva test to see, are her periodontal pathogens going down? It depends on the saliva test. This is all within our means today to offer our patients. This is what we do in our practice. So to me, there is a huge financial win in this. Let me be clear. There's a huge financial win. You're going to do more work. You're going to diagnose more things. And this is from Pearl. Pearl showed average production in an office, definitely not ours, was $254 per visit. After Pearl was implemented, it then increased $74 per visit. Well, if it's $74 per visit, and if this is, let's call it hygiene, and there's 8 hygiene appointments, you basically in one day pay for Pearl just in hygiene. So there's no question there's a huge financial win, but you're not selling more dentistry. You're just diagnosing more dentistry. And with that, diagnostics comes opportunity and enhanced communication. And in the entire process, you're just building trust. And this has been the impact of Pearl and 2D AI in our practice. I really appreciate you joining us today. And so what I'd love to do is handle some questions from all of you. And there are a few that have come up. And so let me just answer a few of those, and you can type in some more as I'm doing this. So Ruka asks, can the porosity of bone also be diagnosed? And the answer is not to my knowledge. It's not evaluating the porosity. There are tests that do that. Cone beam technologies are doing that. I don't believe that is part of 2D AI yet.
So Lou, tell us a little bit about integrating this in the practice.
Okay.
Let us know, you had a pretty big practice. You had a lot of hygienists. We worked together with training. I know some teams feel like they're worried about how is my whole team going to use this? And what would you tell them?
And then I'll answer more questions that came in. I believe that the entire team is trained together. So we were onboarded with training. Now there are videos and additional training. We were all onboarded together. And I believe there were probably back then 2 or 3 initial training, Sheela. I will tell you that I immediately got into this along with 2 of my 4 hygienists. Not everybody gets it. And I will tell you, as a team, everybody has to get it. Do I think it's hard? Absolutely not. I absolutely don't think it's hard. And once it's integrated into your practice, you're really not looking at black and white x-rays ever again. You're just looking at 2D AI images and understanding what they're bringing out. I hope I answered your question.
You did. And then also with native integrations, even easier. So that's the great thing about Patterson. I'm going to turn it back over to you because I do think there are a lot of clinical questions in here. So
Okay.
let's see.
Great. So Janet asks caries versus CEJ. And Janet, let me basically tell you this. Is 2D AI perfect? Absolutely not, Janet. Absolutely not. Nothing is perfect. The studies don't show it's perfect, but 2D AI will continue to advance more and more beyond the 80s, hopefully into the 90s, by the more input and the better algorithms and deep learning. But What it allows you to do, Janet, if something is picked up on second opinion, you're going to go take a closer look. And if it's not there, it's not there. If you have transillumination or other diagnostics and it's been identified by Pearl, you may then want to transilluminate the tooth interproximally. And there are many technologies out there for that, or fluoresce the tooth. But can you still mistake caries in a CEJ, which is your question? The answer is yes. And I want to be clear, nothing is perfect. Livio, you ask, are there any advances in 3D CBCT for AI? And the answer is it's right around the corner. Pearl will be coming out with 2D AI for panorexes. That will absolutely be coming out near term. And from what I'm already working with 2 companies who are coming out with 3D AI, and I do see that not far down the road. It's called how close will it be as far as accuracy. Does Pearl have its own dedicated software? My answer would be, of course, the answer is yes, but it works with your imaging systems. So whether it's integrated into your Patterson system or your DEXA system, that's how it integrates with it. Is that the correct way to look at that, Sheila, if you don't mind me asking?
Yep, we have the standalone, but then we also have the native integration as well as inside of Fuse coming and also with the EagleSoft. So very exciting. No extra screens necessary.
Okay, so I'm just going to answer back to Janet, and she asks, don't be sorry. How does AI differentiate? Well, I want to be clear here that on the slide that I showed you, the gray scale, AI is trying to differentiate, obviously, between a CEJ and caries. There's no doubt about it. And that's, again, back to the gray scales. And I will say, are there false positives, meaning they believe it's that the 2D AI identifies caries and it's not there? I've absolutely seen that. But again, would I rather have a second set of eyes, which is second opinion? And the answer is yes. Next question, still in 3D, is there AI allowing uploading of intraoral scans? Sorry, this just went up. Hang on 1 second. Hang on. 3D AI allowing uploading of intraoral scans and looking into occlusal issues due to heat map of occlusal distances as teeth wear due to disocclusion. I think, Livio, that's just a question about heat mapping with digital scanning. I really think that's another discussion way beyond the presentation of this. You can absolutely email me and I'm happy to discuss that. How does this distinguish a radiographic anomaly? I'd have to understand, Ruka, what you're talking about as a radiographic anomaly. In other words, is it there or is it not there? I need you to reply because I really, this is the limitation of doing chat on this. I just don't know what you mean. Carly asks, with the native integrations, we aren't seeing everything that the second opinion platform shows. Do you have that logged in separately? Sheila, I would have you answer that particular question if you don't mind.
Yeah, there's a lot of additional features, but also in the native integration, majority of all of the identification of pathologies, the case presentation tools, and as well as the practice intelligence side of things, that's living inside of Pearl still. But I do think the teams enjoy being able to have the images taken in the native integration. They just appear there. And again, the same pathologies are identified, the same models are used, and the same case presentation tools.
Exactly. So I know this has been asked a few times. My email is my first name, Lou, and it's at Catapult Education, one word, Lou at catapulteducation.com. You're absolutely more free to follow up with me with some of these questions. I'm more than happy to answer them. I think we're good, Sheila. You got it.
Well, thank you so much, Lou, for the incredible presentation. Your case studies are just so resonating with all of us because we've all been there, and we appreciate you and all you're doing to share with clinicians. Thank you to the Patterson team for joining us, and feel free to reach out to us if you have any questions, as well as with Dr. Graham. And we hope you have a wonderful day, and we look forward to seeing you all soon. Bye-bye, everybody.
Take care.